Hello, everyone. I'm Michael McNutt with Weedy, and welcome to Unlocking the Power of Bidirectional Data Exchange Between Plans and Providers. This Weedy Virtual Spotlight is sponsored by InterSystem. It's my pleasure to introduce Stephen Burko and Julie Smith with InterSystems. Oh, Stephen, you're muted.
Try two. Thanks, Michael. And I want to thank everybody on the line for carving out some time in a hectic week to talk with me and my colleague, Julie Smith, about the potential of unlocking the power of bidirectional data exchange. And I wanted to start off by expanding our conversation just a bit. It is understandable that so much of the dialogue these days right now about kind of opening up that pipe for that electronic conversations between plans and providers centers on electronic prior authorization, or EPA, in light of the looming 0057 deadline. But I just want to remind people for a moment that that's really just the tip of the iceberg of what's possible with timely data. And I think for most people, or the sharing of timely data, and I think for most people on the phone, really it's just a piece of our shared ambition. So to do so, this is just one story from an InterSystems client. It's a health plan, Health First, in downstate New York. And what you see on the screen is the double-digit increases in their compliance rates on time-sensitive HEDIS measures they were able to achieve by automating the identification of time-sensitive care gaps, or actually people who were falling into the denominator of the HEDIS measure, and being able to electronically notify the provider before that limited window closed. So pretty impressive. If our colleagues from Health First were on the line, they would, of course, want to remind everybody these aren't just numbers. When they tell their story, I think one of the things they're very compelling about is there's real people behind these numbers. There's real members, bottom left. They estimate that across 1 year, roughly 5,000 members were able to receive timely follow-up care due to these data-driven alerts. And of course, what is so powerful is they were able to achieve that not by increasing the work, but actually by offloading the work to the electronic exchange. Just a little bit more detail on kind of what's behind the curtain here. Health First was able to use tools provided by InterSystems to actually identify from ADT feeds members who had a change in healthcare status and had a mental health issue, substance abuse issue, something else going on that meant that they needed timely follow-up care as prescribed by NCQA. That identification and generation of daily report then triggered a provider alert, and that in turn, Health First actually worked with their network providers to ensure this was baked into their daily panel management, so that suddenly the provider was able to see within this very limited window, wait a minute, I'm responsible for a member who actually something's changed in their health status and they need care, and now they have time to actually provide that care. I think this is a particularly notable story, because this isn't just something that you can do better by leveraging the bidirectional exchange of clinical data. It's something you can only do if you start to tap into clinical data. So just a brief reminder here that if you try to use claims data for these time-sensitive events, unfortunately, the lags in processing the claims data make it such that by the time you realize there's been a discharge meriting timely follow-up, that window for timely follow-up, which is usually 7 to 30 days, is already closed. So you literally cannot close this time-sensitive care gap if you're wholly reliant on claims data to identify that you have a member or a patient who needs care. Now, I think part of the reason why Health First was so successful is because they have really great alignment between the plan and their network providers. Just on the screen, a little bit about Health First, but you can see that if you start reading through this, that they were actually founded by leading hospitals in downstate New York. So they are very much a provider-sponsored plan, and just baked into their DNA is this very, very close alignment between what the plan is trying to accomplish and what the provider sponsors are trying to accomplish. And on top of that, they had an inordinate number of value-based care arrangements. So they really do share in mutual goals. And I do think that this kind of this alignment between providers and plans is something we're all going to have to get better at as an industry to get some of the numbers that WEDI has shared with us to rise industry-wide. What you see on the screen here is now I've gone back. I set aside, but I came back to e-prior authorization. And I think what hopefully everybody on the phone knows is there's been such, incredibly promising pilots or limited applications of electronic prior authorization using the IGs. I mean, we're seeing, right, like with regard to CRD, upwards of 80–85% of prior auth requests being able to get a quick answer, no prior auth is required. And what I find so helpful about this data is now WEDI has actually given us 2 points in time. And at least if you look at the first two sets of bars from the left, you can see that things are trending in the right direction, right? When we look at the number of payers who have not yet started meeting the API requirements, you can see that this is trending down. As an industry, we are beginning to figure it out. And also that providers recognizing that, this is a very important solution to prior auth, that trending up. But if we pull back for a second, I think kind of the honest look in the mirror is we're not there yet, right? We still have, according to the last survey results, we still have roughly a third of payers saying we haven't even yet started to figure this out. And we haven't crested the halfway mark, the 50% mark, in terms of providers really embracing this and saying that, this is something that we are going to embrace. This is really important. It does seem that, unfortunately, the one thing that everybody agrees on is, boy, wouldn't it be great if we had more time? That's the last set of bars. Now we're getting way past 50%. Wouldn't it be great if we can stagger implementation? And as somebody who works for an entity that is charged by helping payers and providers implement, I can certainly respect that. But I just think we all have to recognize that, boy, wouldn't it be great if this was something that we were so excited about? Actually, we wanted to pull forward implementation industry-wide because we know it's only going to get better when we get up and running. And so when you look at this data, I do think there are some, there's kind of, when you go down to the root cause, and I'm not just talking about prior authorization, I'm talking about really, again, unlocking the power of bi-directional data exchange. And I think everybody is a little bit hesitant to fully embrace it. And remember, this is going to require a lot of change in terms of how on both the plan side and the provider side work gets done. It's also going to, there's individuals in both entities that are, I like to say, very, very good at making a laborious or broken process work. And I think what's holding us back a little bit, the reticence, is both on the plan and the provider side, there needs to be more clearer vision in terms of how we're going to get to ROI. And when I think about it that way, whether it's EPA, whether it's closing care gaps, all the different potential use cases for unlocking the power of bidirectional data exchange, I just hope everybody keeps these two things in mind, because I think this is what we've got to figure out to make all those use cases embraced industry-wide. So number one is we've got to figure out a way to embed this connectivity into existing EHR workflows. I think providers that at least we're working with have been very, very clear about that. hey, rest of industry, if you really want us to embrace this, don't ask us to go outside the EHR. We're doing everything inside the EHR, or we're increasingly doing things within the EHR. If you want this electronic discussion to occur, we will embrace it if it's inside either the existing workflow or the workflow that we're trying to migrate towards. And then on the other side, as we work with plans, I think we're increasingly talking with plans about, hey, it's great if we can get this information coming in from the providers, but at the end of the day, if then we have to go to manual processes to actually translate all this stuff and get it back into all your back-end systems where the work really gets done, that's going to hamper your ROI. Or in a more positive way, plans recognizing that although the information might be coming in from FHIR, I'm not building on a blank slate. I have a lot of other operating systems that speak other digital languages. I need to figure out how to connect those systems electronically to push information into them and get information out of them if I'm really going to see the ROI. Let me pause there for a second. Julie, I don't know if there's something you want to add.
Yes, thanks, Stephen. So I really think about this in a couple of ways, that this is an opportunity to connect the impact that we tend to talk about on the provider side, right? Many of you know I'm a nurse by training, where I talk about the impact in a patient's life, right? How we make their life better. But we haven't always told the story of how we affect the bottom line, and we haven't acknowledged necessarily the complexity involved in getting these problems solved. And this goes back to when we say we can exchange this information, what information is it and what difference is it making? And I think here's really part of the conversation and the opportunity to say, when we really unlock this, when we really do it, when we really share these things both ways, we're not just hitting dead ends anymore. We're actually impacting not just our bottom line, not just the patients, but actually all of the above. And there's a real big opportunity here for us all to be involved.
So this slide is also a little bit of our roadmap, the rest of our time together. We want to talk a little bit about what is going on to kind of make advances in embedding connectivity within the EHR workflows, and then automating the connectivity with multiple plan systems. And then what we want to share at least one story in terms of something we're doing to try to do both together. So when we start on the left with embedding connectivity in existing workflows, EHR workflows. So obviously, I think that one of the big things that we hope we can get some forward progress on is getting everybody involved in TEFCA, right? If everybody can be in one trust framework, it's going to kind of help us get that scaled effect. But I think there is some good news here. And you can say piecing together multi-point provider connectivity. And I just want to give you kind of pragmatically kind of where we're seeing plans go in advance of having kind of that one trusted framework that everybody's part of, because forward progress is being made. So increasingly, when I'm working with plans, we kind of go through this exercise together. So the plan kind of looks at their participating providers, and they say, do I have one or two dominant EHRs across my provider network? And when I look, if those one or two, let me look at the tools that have already been put out by that EHR that are coming. And can I actually leverage that tooling to reach a broad share of my provider network? Then the next thing they do is they think, all right, now let me look at my participating providers who are not using that EHR. Now we have starting to have more smart on FHIR apps. Again, don't let the perfect be the enemy of the great. Are there smart on FHIR apps that I can at least leverage to get kind of that portal or that connection to me embedded into another big slice of my provider EHRs? And then the last thing they look at is they say, all right, who's left? And is there a provider within my network that really takes care of a lot of my members, a lot of the patients, and do I need to invest in point-to-point connections? And I will be honest, sometimes kind of the pragmatic strategy is a little bit reversed. They start with saying, all right, do I have a dominant EHR? Now, who do I want to do point-to-point connections with? And with regard to everyone else, can I reach at least most of them through a smart on-fire app? And so not yet at the point where there can be one hub through which all providers and payers are connected, but significant progress from that kind of overwhelming kind of barrier to saying, wait a minute, if I want to start this bidirectional flow of information, each plan has to connect with 1,000+ individual providers. Now they're starting to recognize that, hey, if we can connect maybe through 3 or 4 different channels, we can reach upwards of 85-90% of our panel. So I think this is good news, and I think everybody should, if you're a plan and you haven't adopted this strategy, it's a pretty simple strategy to walk through while we wait for maybe trusted frameworks to continue to mature. And if you're a provider, I would encourage you to talk with your plan about, have you thought through a pragmatic approach that you can get yourself embedded within my desired workflow. But again, that's only half of our continuum. So let's go on to the other half of our continuum.
So when I think about this, I think about what Stephen has framed up so far is really the provider to payer connection. And then you actually hit well, now it's in my health plan ecosystem, but where does it go from here, right? Because the reality is we all have huge numbers of applications that we currently use to solve real problems that we need to continue to use. And the ability to actually have that information flow and make sense can be a challenge, because there remain silos with all of the different formats that data comes in on, right? Whether that be FHIR, HL7, et cetera, and or the fact that these downstream applications really have robust investment, right? And have key influence over the productivity of the organization, and yet the information can't reach where it needs to go. And so you still end up with a lot of disconnect and discord because of that. And that's particularly true if you end up with lots of applications that have proprietary formats. I think back to the early days of provider organizations moving to EHRs, and we were flabbergasted at the number of formats and the types of flat files and proprietary things that were coming out of all the various applications. And over the last, 15 years, we've certainly seen more alignment. But it is unrealistic to think that the downstream applications would be ripped and replaced, right? Addressed in a different manner. And so really we need to solve for the problem of, how do we keep this information flowing in a way that will allow for all of the value to be obtained. And if you go on to the next slide, I think that there's a really key principles that you need to consider when you do that, right? So just like healthcare providers have done a lot around integration hubs and governance to make sure their applications are connected. I know when I was leading a large 500-bed hospital, I was responsible for example, 149 applications, right? They all had to talk to each other. And so I think, health plans are certainly in that same place to say, when you think about how you need to solve this, you need to make sure you have the scalability, the disaster recovery, the security, sort of all of those same principles in place when you start connecting these siloed systems to each other, right? Because your risk increases also, and you need to have data governance, auditing, all of those tools in order to have the interoperability ecosystem that you're looking for. And it really requires something that is healthcare native, that understands healthcare language and can understand and speak in all of those formats in a way that then can make that meaningful. Next slide. So particularly with InterSystems, we've had the opportunity to engage with Epic Payer Platform. And many of you know, Epic Payer Platform occupies a unique space in the market for those health plans that have the majority of their community on Epic EHR data. And so it facilitates that data flow on that first half of the problem, right, that Stephen really outlined, to say there are so many provider organizations out there, and that challenge of whether it be those point-to-point connections, those smart on fire apps, whatever that may be, to get the data from a provider to a health plan is significant. And Epic Payer Platform solves for connecting systems with members, with health plans, to get it into through those gates and in that door to the health plan ecosystem itself. And it really provides that opportunity and facilitates that in a meaningful way. Next slide. But the challenge is how do you get it to connect with the rest of you, right? One of the things that when we think about unlocking clinical data value, right, bi-directionally, is making sure that we then connect it into the systems of record, the systems that matter, the systems where you're actually making decisions. And those decisions may be quality gap measure decisions, right? So not only identify those gaps, but also report out on them, right? It starts with just the basics of matching eligibility, right? Member rosters, and then actually going more complex workflows for things like care management or ADT notifications, right? This speaks to the opportunity involved that Stephen referenced way back at the beginning, right? With Health First addressing quality measures that require clinical data, that are those follow-up measures, right? That have 7-day or 30-day look-back criteria that you have to answer quickly and meaningfully. And so that's where in the case of InterSystems, we developed the InterSystems Payer Connector that facilitates that information flow from Epic Payer Platform into the larger health plan IT ecosystem, specifically to do this, to unlock that power of the clinical data throughout the health plan and no longer require those systems to sort of manually send this through or navigate these things individually, but actually do it collectively as a whole. Next. And I think there's some key principles that come into play when we look at the connectivity opportunity within a health plan ecosystem to really get that value out of clinical data. It always starts with who are the members, right? Plans are complex, and it's important to understand that the data that's coming in really needs to be targeted and focused on the membership roster. And so identifying that just out of the gate. And then actually connecting it into and routing it to the systems that are needed, because this actually can support things, not just clinical data, right, but claims data, things for quality analytics, all of those pieces that facilitate that flow and really transform it in a way that matters, right, to make it make sense. Because, many of these things will start in proprietary formats or, in this particular case, Epic specific schemas. And so we want to make sure that then they make sense from a larger plan need perspective. And then you really need your integration tools that you would expect, right? Whether that be monitoring, auditing, trusting those data flows, being able to validate that, and being able to control and validate the versioning and the utilization therein. And of course, you need to use it in the way that your environment is required. And so that includes whether on-prem or managed service, there's an opportunity to say, making sure it meets your deployment needs and models and within a health plan space. Next.
So this is not just a concept. It's something. It's a live service that we are providing, and we thought just might be helpful for you all to see it in action with an early adopter. This is a very simplified version of the architecture. It's pretty similar to what Julie just showed you. It's just been applied to a specific customer. Just two things I want to call out on this slide, that in terms of kind of how they're putting Epic Payer Platform and InterSystems Payer Connector to work together. Number one, I just want to call your attention to that box that says Health Share. Just think CDR there. Clinical data repository. They've decided that instead of connecting directly into their backend systems, they actually wanted to license a CDR for us and create one source of digital truth. So that's a little bit of a wrinkle in terms of how they're using it. The other thing I want you to note is that box below it, the connectivity solution. So again, as you can see, kind of represented by the number of network providers. This was definitely a health plan where Epic was by far the dominant EHR with among their participating providers, but it was not the only one. And like everyone else out there, you got to solve for all your members. And so what they recognized is if they could connect into now their CDR, all those mappings on the back end that Julie was talking about between the information coming in from not just Epic Payer Platform, but from all the other EHRs, now that all can be use the same mappings to get to their back end system and to get the information back. So let's put this to work a little bit. I just want to share some of the things you're discovering. Kind of phase one, and they're getting to bidirectional data exchange kind of in two phases. There's actually a third phase. I don't think we're going to get into it, but phase one is what sort of information can you now get from the provider side via Epic Payer Platform? What's all that rich data that you've been exposed to? And I just want to give you a sense of all the stuff that they're finding that they can pull out. And what's clear here, what I want to be clear here, this isn't about just being able to look into Epic Payer Platform and see all this information. It's absolutely about being able to pull it out, to structure it, to normalize it, so then it can be pushed into all their back-end systems. So you can see just, the ways these come out formatted from Epic Payer Platform, so ADTs, CCDs, ADRs, candies. I won't go into the detail, but these are all sorts of different types of feeds and reports that a payer can get via Epic Payer Platform. And you can see for our case study institution, just when we start to convert this to individual elements or structured data or associate it with specific members, all this information now is available and can be pushed into all those back-end systems that Julie was talking about. So now they can really, when you're doing risk adjustment, when you're doing identifying care gaps, and you're trying to do kind of population health management, suddenly all those back-end systems you have can benefit from this additional data stream. All right, but bidirectional, we got to go two ways. So let's go on to the second part. This is kind of what they're beginning to really work on now with us. And that is, so you've got the information coming in from their operational systems into their CDR, their digital source of truth. And they want to be sure that they can apprise all the way on the other side providers of actionable information from all the things that they're getting from their back-end systems. So if you're not familiar with Epic Payer Platform, Epic Payer Platforms has to have certain things, pursuant to certain specs or formats to be able to ingest that information to then put it into certain documents that they can expose to the providers through their EHR. And so that's what's going on here. Some of the use cases, I mean, the big use case going on is close gaps, close gaps, close gaps. To migrate to a situation where the quality engine can identify, hey, I have a patient, they have a care gap or a coding gap, if we're looking at risk adjustment, and I can apprise the clinician within their workflow, hey, when you see your patient, here's things that would be really good if you could address. And what we hear from the providers is, boy, if you can give me that information pointed at the right point in time, I will be able to act on it. I do want to share kind of one early kind of piece of results, if you will. I think this is really promising. And going back to where we started, the potential power of unlocking that bidirectional flow of information, and what the customer has already called out to us is they, and this was as of last year, in a second, putting a pin in, I'll tell you where they're going this quarter. As of last year, they had just hooked up 5, which comprised just 2.5% of their network health systems. They had kind of hooked it up into this electronic interchange, and they had already captured data on 1.4 million members. Whoops, I got that wrong. 150,000 of their 1.4 million members. But the math is simple. They connected up just 2.5% of their health systems, and they had already captured data on 11% of their members. So they're really starting to be like, this is really going to work. I think what they're really excited about is they would underscore, if they were on the line, that those first 5 health systems that they connected to, while incredibly highly regarded health systems, did not actually account for an outside share of their members. And where they've been focusing on this quarter is now let's start to hook up. They're starting to hook up those health systems that really care for a dominant number of their members. So they're really excited to see where this ratio shifts when they rerun the numbers at the end of this quarter. So I hope that's been helpful, and I just want to give the last word to Julie here.
Well, Stephen, I think it's really important to acknowledge that this is not an easy problem to solve. If we thought it was, right, it would have been solved a long time ago. And we have all collectively put in huge amounts of level of effort in order to determine a best path forward. And really, when we have reached the point, when I look at the conversations over the last maybe 18 months or so, we've gone beyond saying, hey, we have a regulatory driver. We need to solve, for example, for EPA, and the access APIs are obviously coming up with CMS 0057. But really now we're starting to get glimpses of the opportunity within health plans to use this clinical data for more. And when we say we use this clinical data for more, it's not just internal to the health plan IT ecosystem itself, but also sending it back to the providers. And it's really essential that it makes sense on each of the steps along the way, right? It's meeting the need of the user in that particular application and for that particular use case. And so it's been really exciting to see this roll out. We happen to be a company that has been doing interoperability for decades. It's certainly what we do at our core, but seeing it move into health plans and seeing it deliver value has been a phenomenal experience. And I think that we all can learn from how to leverage it better in order to build that out and get the value that's possible. I think it really goes back to maybe your first slides around the health first use case of, when you start thinking about and realizing what it can deliver, you really, there's an endless list of opportunities for things that historically have been very heavily manual with high overhead.
So, hey, Michael, we went a little beyond our 30 minutes, but I think we got ample time for some questions.
Definitely. Are there, and I see that there are folks in the chat right now. We'll work from the bottom up. Brian Morris asks, please elaborate on your focus in the case study with 150,000 members. What mix of payer LOB, commercial, Medicare, inpatient versus outpatient, medical versus pharmacy?
I don't know, Bill, do we lose Michael?
Yeah, Michael, you're really faint. It's a little bit hard to hear what you're saying.
Sorry, my microphone was was off angle here. Can you hear me better?
Yep.
All right, here we go. Back to the question. Please elaborate on your focus on the case study with 150,000 members. What mix of payer, LOB, commercial, Medicare, Medicaid, inpatient versus outpatient, medical versus pharmacy?
I didn't hear the second part of the question. I mean, the first part of the question is just, we obviously we're excited about at least, one of our customers really kind of leveraging a pragmatic approach to start to get to a network effect with bidirectional data exchange. They were, again, a plan that had an outsized number of facilities among their participating providers who use Epic. So it was a logical place for them to start. But what the ratio was alluding to and what the customer was excited about is, we're at the beginning of the journey here, and they realized that just by connecting up last year, a relatively small number of their network providers, how many of their members they were already beginning to touch. That was the five. We connected 5 network providers and not even the network providers who are our dominant network providers. And we were already impacting the lives of 150,000 members. So that's the 5150. I'm not sure about the second part of the question, but if I'm going to kind of make a guess there, um, it goes to, well, what's the type of data that's flowing? And I'll refer you back, and I think you're going to send out the slides, right?
Correct.
The cool thing is, once this kind of pipe is set up, if you will, it's all the data that I alluded to. It's all those reports and how they're converting it to all those data elements. So it's not specific to any product type or any, it goes from CCDs to ADTs to ADRs, which is a report that can be generated that has additional data that's relevant to claims admin. But then it also, you'll see there's another report in there, and I think it's called Candy, right, Julie?
Andy. Mm-hmm.
And what the plan recognized is actually under HIPAA, they can get a lot of non-encounter specific data to help document with quality measures. And so that became another rich source of information that they were able to kind of ingest from EPP. So a broad range of data types. I hope I did a good guess. Please come back if I missed your question.
Thank you. Soraya also has a question. How can or will this bidirectional flow support quality measure reporting and fee-for-service payments for CMS?
So under fee for service, so traditional Medicare. So obviously there's lots of opportunities in terms of using this bidirectional flow of information to document the closure of care gaps. But I think, again, going back to that health first example, I think what's really exciting is this ambition that can the health plan help to call attention to the providers within their existing workflow at the right point in time. Hey, here's a care gap here's a potential care gap that's relevant to your patient. And you know what? In an ideal world, that patient's about to walk in your office. So be aware of this, because I think it then becomes more of a layup for the provider to close it. So there's really two things. One is just the documentation. As we all know, there's a lot of care gaps that providers close, but there's insufficient documentation to actually reflect that. But then there's the second, I think, even more powerful opportunity to help call attention to a care gap at the right point and place and time.
Excellent. Follow-up question from Soraya. Do you think payers having more information on the patient that payments could change with SDOH?
That's a great question. In terms of, yes, we talk about we need to break down the silo between claims admin data and clinical data. And honest moment, that was very much the focus of our conversation today. Obviously, we increasingly have SDOH data. I do think that's where the customer gets really smart about that. They've actually decided they actually want to have one digital source of truth. They want to have a CDR. And so you can start to bring in other data sets. Honest moment, we focused on our story on InterSystems payer connector. And so that's really trying to automate and get that scaled effect between payer and provider. Obviously, increasingly, we've got third-party sources to bring in SDOH data. And I think it could be even more powerful. It can definitely be more powerful with things like population health management and even care management. But as somebody who spent a lot of time deep in the coding world, we do need people to start filling in that information. So for the geeks out there, I'm sure we have this great set of Z codes, but they're only as good as when they're filled in. So for people who aren't familiar with it, Z codes or SDOH codes, said loosely, But all too often, when you actually go look at the data, a lot of those fields remain blank. So I think definitely something we want to tilt for in the future, pull it forward now. But I'm a big pragmatist, and I don't want to let the perfect be the enemy of the good. And I think just getting that bidirectional flow of data going, that's the first step. And then the more data we can marshal and the more data sets we marshal, so much the better. But just having that data set available, if we can't get it into the natural flow of information, it's going to be another situation where we have more data, but we haven't activated that data.
Excellent. A couple more questions to come in through private. Is InterSystems Payer Connector built specifically to work with Epic?
So I'm certainly I can jump in here, Stephen. That particular product is built for connecting and leveraging its expertise and sort of special sauce related to Epic specific schemas, formats, document types, etc. But it builds the integrations the whole way through. Right. So what you may remember in one of the diagrams that Stephen showed was that, right, once you move from payer platform to payer connector, and then we connect to the IT ecosystem within the health plan itself, right? Those things between payer connector and the rest, right, whether that's UM, case management, or anything else, can be used no matter what is actually hooked in underneath from the connection side. And so we solve interoperability in a lot of different ways. That particular sort of subset slice with the payer connector is specific to Epic Payer Platform listed in the Epic showroom, but it solves for the connections that go to the downstream systems and back, and certainly leverages our technology that we use more universally in health plans, right, with the standard adapters or providers in that larger ecosystem.
Excellent. Thank you. Another question. What use cases are being prioritized for pushing actionable information into Epic Payer Platform via the connector?
Hi, Michael. I couldn't hear you.
Sorry, I'll try again. Can you hear me?
Oh, there we go.
Okay. What use cases are being prioritized to pushing actionable information into Epic Payer Platform via the connector?
I think we've already alluded to them. So, I mean, if we're talking specifically about kind of our early customers, what are they prioritizing with us? Again, it's closing gaps. And so we talked a lot about care gaps. And the health plan really wants to marshal the information that they can distill from their back end systems to identify care gaps and be sure that information flows via payer connector and payer platform to the provider at the right point in time. There's two other things I'll call out really quickly. Number one, there's also issues around can it also help kind of capture documentation in terms of the complexity of the patient. There's tremendous, for those who are less familiar with the coding world, there's all sorts of things that a physician has to document, or a clinician, to be more accurate, has to document about their patients on an annual basis. So that documentation is only as good as 1 year. So, can the plan help call the provider's attention to kind of things they need to get into the medical record for this annual cycle? But I think it's fun to dream. And what's really interesting is when we talk to the customers, some of their dreams in terms of where you can go once you've really kind of got this bidirectional flow of information set up. So just two things. Number one, I mean, so obviously, actually, before that, another one is electronic prior authorization. It's the same thing. Like, so many of us are building, kind of a custom fit pipe just for electronic prior authorization. Although a lot of our customers are thinking about it the other way around. So they're building this whole infrastructure for bidirectional data exchange. And one of the use cases will be for prior authorization. But in terms of kind of dreaming, what's really fun is when you start to talk to the plans, they start to think about how they can really begin to transform work once you have what they called kind of a unified, clinical knowledge that if everybody knows that an appointment has been scheduled, people don't have to keep peppering the patient or the member to schedule that scan. And then I think another thing that's really interesting, and I'm going to allude to one of Julie's slides. One of the most popular consumer apps out there is MyChart. So we've been talking about just kind of this bidirectional flow of information between the provider and the plan. But I also think it's really interesting that within EPP, it also connects you to MyChart. So there's these huge opportunities to also improve the flow of information between the plan and the member or the patient. So two or three things that are definitely front and center. But I just want to share some of the enthusiasm we hear from our clients in terms of once this thing is built, where they can go with it.
Excellent. Sue Ann has a question. For CRD, CDS hooks are used to hit a specific payer endpoint. Does this solution help to minimize the need for the EHR to target a specific endpoint for each payer? Does this place some sort of routing solution in the middle?
So I don't know, Julie, because I know Epic Pay, I don't want to speak on behalf of Epic because in terms of what's baked into their solution, I can talk about like when you go to that thing about how we're adding our solution.
Yeah, and I think, Mike, what I heard there was really around what functionality is already connected through the Epic ecosystem that then we can leverage. And for our customers who are already live with the first version of our software, it's really focused on ADTs, CANDIs, CCDAs, ADRs, and it doesn't. And there's a lot more coming on the roadmap. But this is very much a what data can come out of payer platform to be leveraged across the rest of the health plan ecosystem, and we're very careful not to speak to their roadmap or their functionality. And so as things develop, we would certainly take a look to say what makes sense to connect further, but we can't speak to theirs. Yeah.
So obviously, for those of you who don't know, I hope many people on the line know, honest moment, we have an iron in this fire. We have a solution for CRD, DTR, and PAS. And so we support those endpoints. And I do know that some of the customers we're working with, they are using our solution at least for providers on other EHRs. So I'd love to go back to that slide, a piecemeal strategy, which is better than point to point. But I do think that we're definitely gonna, those IGs are very, very important. And I think we all want to get to a world of FHIR-based APIs. And at least it's gonna have to be part of your solution, whether you use us or somebody else.
Great. Kay has a question in the chat. Will provider data like credentialing, licenses, etc., be interoperable amongst providers and payers?
Provider data like credentialing, licensing.
So today, there are some applications out in the ecosystem that do that. That's not part of the sort of clinical data bucket that we've covered in this conversation. There are certainly ways to do that, from provider credentialing and network coverage and all of those pieces. Those are not the first use cases specific to the payer connector, where it's really focused on the clinical data of the members themselves, right? And so there's some of that comes through in the eligibility file, right? Because we're matching up the member roster and understanding, right, with the systems of record for that. But that's where that boundary lies.
Excellent. Thank you. Question: Can a plan repurpose mappings between InterSystems payer connector and a plan's backend system for other applications?
You want me to do this, Julie, or you want to do it?
Sure.
So I think this goes back to the case study I was sharing, and the short answer is yes. Once we've done those mappings for you, So mapping from, in this case, the payer connector to the plan's operational systems. Yes, you can repurpose those mappings for any other things you want to hitch your cart to. And as a matter of fact, and I think I alluded to it, not only can you, I think that's really smart. You shouldn't have a system, I think we want to all get away from I have this, very siloed solution and I have to do the mappings to my backend systems for, this specific solution. And now I have another solutions and I have to replicate those mappings. It's one of the reasons why I like the example with the CDR that I showed. They're doing the mappings, or we're actually doing the mappings with them between the CDR and all their systems. And then they can plug everything else into the CDR and the mappings are done. Great question.
All right. And the final question that I have is Payer Connector now generally available?
I'm gonna tell you,
so
Julie.
I mentioned, yeah, sure. So right. So I already mentioned, I think briefly that specific to the Payer Connector, which connects to Epic Payer Platform, it is listed in the Epic showroom and it is generally available. Right. Interoperability solutions more broadly are obviously also available, but I think that goes back to part of what I showed on one of the slides of just being thoughtful about how to solve this for the long term and how to make sure that you're getting sort of all of the features needed in order to solve this. So specific to Payer Connector, yes, it's available for those plans that are using Epic Payer Platform. It is GA, and then just thinking about the broader ecosystem, making sure that you consider what your environment needs are.
Excellent. Thank you. Asking the audience, are there any other questions? Julie, Stephen, as always, a fantastic presentation. We thank you so much, not only for the content, but also to InterSystems for sponsoring this event. Once again, this was Unlocking the Power of Bidirectional Data Exchange Between Payers and Providers, a WEDI virtual spotlight sponsored by InterSystems. Please visit wedi.org and click on events to check out all our upcoming educational offerings. On behalf of WEDI, have a great day.
Thanks, Michael. Thanks, everyone.